So it's Dr. Mo here from Inspire Medics. If you're just joining us, we have slightly overshot our previous webinar. So we had an interview webinar before this where we were interviewing candidates for the ambassador program. So we are getting started. I can see a few of you have already joined: Angerin, Nalaki, Letitia, Natalia. Hi, Natalia. Kiran, Neve, Sadia, Samangi, Tafida, Yusur. So welcome all. We'll get started in a few minutes. What we'll do is we're going to live stream to the Facebook group. Dr. Sandhu will be joining us soon. Whilst everybody is joining us, if you can let us know where you're joining us from in the world and which exam you're sitting. So for example, my name's Dr. Mo. I'm joining you from Coventry in the UK. It's 6 p.m. local GMT time, local time here. And if you're sitting the PLAB 1 or the PLAB 2, so that we roughly know which exam you're sitting. So if you want to type into the chat box now, and then Dr. Sandhu will do a shout out for your names and which exam you're sitting and where you're joining us from. And when he does that, I'll live stream into our Facebook group so that those of you who are joining us from Facebook can see. And then of course we can get started. So today's teaching topic is an hour's teaching session. It's going to be on psychosis, schizophrenia, and PTSD. So we've got psychiatry slant to today's teaching session. And as always, we always try and teach you the most important information you need to know to pass PLAB 1 and PLAB 2. So I can see the comments are coming in, which is fantastic. I'm going to wait for Dr. Sandhu to do the shout out. So I can see Sultana, Sadia, and Kiran and Neve have already written into the chat box. And so what I'll do is I'll start off with the shout outs to begin with, actually, whilst Dr. Sandhu joins us. So Sultana, welcome. You're joining us from London and you're sitting PLAB 1 in May. Sadia, you're also in London and you're going to be sitting the PLAB 1 exam. Kiran from Glasgow. Kiran, you didn't mention which exam you're sitting. Neve from London, PLAB 2. So Neve, obviously you've got a PLAB 2 date by the sounds of it. There's been lots of obviously issues around securing PLAB 2 seats because of the COVID pandemic, which has been unfortunate. Tanya from Wales, welcome. You're sitting PLAB, not sure if it's PLAB 1 or PLAB 2. Natalia, welcome. West Iberia, it's 11 p.m. and you're going to take PLAB 1 in May. Amazing, excellent. For those of you who are sitting PLAB 1, just to let you know, our question bank for PLAB 1 is currently free, but we're going to improve on it. And there's a lot of discussions and talks around, there are other questions banks that are out there which are better, but we're going to try and improve our current question bank to make it even high quality and more like the real exam. So I'm going to hand over to Dr. Sandhu now, who's just joined us whilst we live stream this to our Facebook group.
Yeah, perfect. Thank you very much, Dr. Mo. So I hope you're all keeping well, guys. So we obviously had a bit of an issue with the website, which has been resolved over the last week or so. And it also explains why most of you probably didn't get the email either for this webinar. So it would have gone to your junk mail. So our team's working on that. So a couple of glitches, which hopefully will be ironed out over the next week or two. And then we should hopefully be up and running as we were normally. But obviously it's good to see the faces. Let us know whereabouts you are in the world, what time it is, what the temperature is as well. In the UK, it's just gone 6 minutes past 6. It's just getting dark now. Raining as well. A little bit nippy outside, probably 6 to 7, 8 degrees. So welcome, Fatima. So you're preparing for PLAB 2. Again, also, yeah, let us know which exam you're preparing for as well. And we'll give you a quick shout out before we get started. We will stream it as well to the PLAB 1 iMedics Facebook revision group. So if you're joining us on there, thank you for joining us. I don't think you've done it just yet, Mo, have you all? Okie dokie. Right, guys, don't be shy. Tell us where you are in the world and we'll give you a quick shout out while other people are joining. So we've had a few hands raised. There's some more people joining us now, which is good. There's making sure that everyone's in the... So Maduri has responded. Fantastic. Let's have a look. So we've got Maduri from London. Fantastic, Maduri. Which exam are you preparing for? Raymond Lorgie Vincent from India. Welcome, Raymond. What time is it in India? I think this must be quite a long time, 5-6 hours ahead. Fatima's doing PLAB 2. Okie dokie. It's 11:45 p.m. in India. Fantastic. So Raymond is really committed to studying. joining us that late in the evening to join us for this webinar, which is fantastic, very good commitment. It is now streaming live because I can see it on the corner into the Facebook group. So welcome to everyone who's joining us from the iMedics PLAB 1 Facebook revision group. If you have any questions, you can type them underneath the live video. Samangi Fernando is joining us from Southampton, preparing for the PLAB 2 exam. Welcome, Samangi. Mo, we have got another webinar after this, which has 1,300 signups, which can be quite a monster event. So we'll be streaming that to YouTube. That's more for students applying for medical school in the UK. It's going to be a very popular event. So we should probably get started, I think, Dr. Mo, without further ado.
Okay, guys, so welcome to this teaching on PTSD, psychosis, and schizophrenia. And we're going to be covering the latest UK medical guidelines, which you will require in terms of knowledge for passing the PLAB 1 and the PLAB 2 exams. So let's get started. So I'll be covering psychosis, schizophrenia. Dr. Sandhu will be covering PTSD. There'll be plenty of opportunities to ask questions at the end of each mini presentation. And of course, we'll be talking through some products and promotions that we have on offer, as well as our social media channels, which you may want to follow for ongoing learning during the day, during the week, as we post into our social media handles. So let's start off with a recap. What is psychosis? So it's important to know that there is a link between psychosis and schizophrenia, and I'll cover that very shortly. But let's start off with what psychosis is. So the definition of psychosis is that it is a significant alteration to perceptions, thoughts, moods, and or behavior. And you can break down psychosis symptoms into two types. Those are positive symptoms and negative symptoms. And the reason that's important is because when we come onto our slides on schizophrenia, those symptoms are going to be important in diagnosing the actual condition. So in terms of positive symptoms, these are things which you can think of as being additive to the patient. So things that occur in addition to what they may experience on a day-to-day basis. So obviously as human beings, we see things, we see other people, we hear other people, and that's the normal part of reality. But when you start losing touch with reality, in the case of psychosis, you can start to experience positive symptoms, which can include hallucinations, delusions, and also disorganized behavior, speech, and thoughts. Now, don't forget, hallucinations can be auditory, so things that you hear, and they can be visual, things that you see, and they can also be sensory. And these are perceptions which occur without any stimulus. There's no obvious thing there which is happening. Small example, let's say if I see a friend, let's say Dr. Sandhu across the street, I'll say hello. But let's imagine I saw another human being from the past. Let's say it was a Napoleon from Napoleon Bonaparte across the street. Now that's somebody who's passed away who isn't there, and that will be a visual hallucination. Also, delusions are considered positive symptoms. So these are positive rank symptoms, and these are basically fixed or false beliefs. So it could be something, could be an example would be somebody believes that they are the second coming of Christ. That's a delusion. It's clearly not true for that individual. And then disorganized behavior, speech, and or thoughts is also classified as thought disturbance. This is where the logic behind the individual's behavior or speech is illogical. So they may, for example, be talking about ducks swimming in a pond, and all of a sudden they're talking about, for example, Australia, and there's no clear connection between the two. And then they're talking about being followed by the government, and so that their speech will be that their behavior, the thoughts may be very, very disorganized. In terms of negative symptoms, the way to think about negative symptoms is that it takes something away from the patient. So positive symptoms add something to the patient's experience in some way, shape, or form, whereas negative symptoms take away something from the patient. So this all falls under negative symptoms, which will be emotional blunting. That's where the patients don't feel emotions as normal as a well individual would. So happiness would be blunted, anger would be blunted, sadness would be blunted, all the emotions get blunted, and so they feel them less so than a normal or healthy individual. Reduced speech, loss of motivation, self-neglect, and social withdrawal are all relatively self-explanatory, and these are, of course, are negative symptoms. Just think of them as something being taken away from the patient. So reduction in speech, loss of motivation, a reduction in the patient's self-hygiene, which is self-neglect, social withdrawal, something's getting taken away. It's a very good way of knowing what positive and negative type symptoms are. Now, the key question here is, what's the association between psychosis and schizophrenia? And the answer to that is that schizophrenia is a type of psychotic disorder. There are other psychotic disorders out there, drug-induced psychosis, bipolar-induced psychosis, for example. But schizophrenia is the most common psychotic disorder. And that's why it's a common topic that can come up in PLAB 1, but also PLAB 2. And the UK medical guidelines use the ICD-10, or i.e. the latest ICD classification and definition when it comes to producing UK guidelines. So the two are very closely linked. So if you've read up on the ICD-10 guidelines, you'll recognize this information. But the key thing to know is UK medical guidelines for schizophrenia use ICD-10 classifications and definitions. So in order to diagnose schizophrenia, it's very important to know that the symptoms must have been present for 1 month or more for most of the time within that month. So clearly there's a time limit on or a time frame on schizophrenia in order to make a diagnosis. So you can't make a diagnosis for schizophrenia on an individual who's got auditory hallucinations for 3 days or 5 days or 7 days. It has to be more than a month, 1 month or more. And there's two ways that you can diagnose schizophrenia. So there is the definition that we have up at the moment, which is mostly positive rank symptoms. But then you also have this combination of positive rank and negative rank symptoms. And it's quite interesting because with the first definition that NICE has, you only need at least one of the following to be present for a month or more for most of the time within that month in order to make a diagnosis of schizophrenia. And those things are auditory hallucinations, thought disorders, so that could be thought echo, thought insertion, thought withdrawal, or thought broadcasting. So thought broadcasting, for those of you who are not familiar with this, is the patient's thoughts are broadcast, so they're expressed in different places apart from the patient's mind. So example would be Mr. Smith is a patient who has schizophrenia. He's experiencing thought broadcasting, which means that his thoughts that he thinks about are perhaps played on the radio. He believes they're played on the radio or television or on YouTube. That's called thought broadcasting. Then you have delusions of control, influence, passivity, and it can also refer to body or limb movements or specific thoughts, actions, or sensations that the patient may have delusions in reference to. So as we covered, delusions are basically fixed or false beliefs. So for example, this is a mobile phone. That's fact. This is a fact. This is a smartphone. Whereas if I said, this is a device which can help me fly, is a delusion, because this is a device which cannot help me fly. It may help me book a plane ticket to another country because I can use an app, but the device itself cannot help me fly. So that will be a delusion or a type of delusion that a patient may have. And then the other definition which falls under the category of being able to make a diagnosis is persistent delusion of other kinds that are not culturally appropriate. So what does that mean? Delusions which are not culturally appropriate. Well, so what are culturally appropriate so-called delusions? A good example will be religion. If an individual believes in God, although obviously they can't show to another individual that this is God, they believe in it. And so it's considered culturally acceptable within the world because enough people believe in that religion or that idea for it to be culturally appropriate. However, if an individual, let's say, says, I am the second coming or the third coming of Christ, as an example, that will be culturally inappropriate because there would have to be specific things that occur for that event to be realistic. Perhaps in the scriptures, the second coming of Christ would occur in a certain part of the world. Whereas if somebody from, let's say, England said they were the second coming of Christ, that's unlikely because it doesn't fit in with the historical text or the religious text. And so that will be considered culturally inappropriate, and it will be considered a persistent delusion of another kind. So the second way this is the first way you can diagnose schizophrenia, which is to have at least any one of the following most of the time for a month or more. The second way you can make a diagnosis of schizophrenia is, again, to have the following symptoms present for a month or more for most of the time. But what you'll notice here is that you have a combination of positive and negative ranked symptoms that you can choose from. So the positive ranked symptoms would include persistent delusions, any form, a breakdown in the interpolation of thoughts, so in incoherence or in irrelevant speech or invented words. But then you have negative symptoms, so catatonic behavior, negative symptoms which we covered on the earlier slides: emotional blunting, reduced speech, self-neglect, but then also a significant or consistent change in the overall quality of some aspect of personal behavior, manifesting as a loss of interest, aimlessness, idleness, self-absorbed attitude, or social withdrawal, which again is essentially a negative rank symptom. So just to recap, two ways of making a diagnosis of schizophrenia. One is primarily based on positive rank symptoms, but the other has a combination. It can be a combination of positive and negative rank symptoms, but it is any two of the following bullet points that we've mentioned. Now, it's very, very important to know that as junior doctors come into the UK, you would not be expected to make a diagnosis of schizophrenia yourselves. A psychiatrist or a specialist doctor would be making, a specialist psychiatric doctor would be making that diagnosis, but it may be that it's a PLAB 1 question, and the question may be, what is your top differential? Or a PLAB 2 situation, which is, you may have to explain to a patient that this is my differential diagnosis, which would fit in with the ICD-10 and the NICE guidelines. Okay, moving on. How do you manage patients with schizophrenia? So the key take-home message here is you need to risk stratify the patient. And you need to risk stratify them into high risk or not high risk. And by being able to do that, you will then be able to select the correct management option. So what do we mean by high risk? So high risk means basically that they are very high risk of hurting themselves or others. A good example will be, let's say Mr. Jones comes into A&E, into a London hospital, and he says, I want to kill myself. Now, it's not uncommon for psychiatric patients to make statements like that. I want to kill myself or want to hurt myself. That by itself doesn't make the patient high risk. What makes the patient high risk is if they would say, well, I want to kill myself. I've planned it. I'm going to jump in front of the 9 o'clock train tomorrow, leaving from London Euston, and I know which platform I'm going to jump from. And I've checked all the information online, and I've prepared my will as well. Now there you have a patient who A, has planned something, B, has actioned things like his living will, and 3, he's ready to go ahead at a specific time, date, and place. And for that reason, that individual becomes very high risk. I mean, he's high risk, but he's very high risk. And so if you have a patient who you suspect of having psychosis or schizophrenia, and they're high risk, and that could be to themselves or others. Maybe they've had thoughts, paranoid thoughts that somebody's following them. They could be their next door neighbor, and they think to themselves, okay, they want to kill their next door neighbor. That's high risk. And for that reason, that individual, that patient needs to be seen same day by a specialist for an assessment. So it would be usually a psychiatry specialist, a consultant, or a senior psychiatric doctor. So that's high risk is equals to same day specialist assessment. Now, what do you do if the patient's not high risk? So an example would be, so they're not high risk to themselves or others. So they say they want to hurt themselves, but they've got nothing planned, and they never plan on acting on those thoughts that they have inside their head. In that instance, you would try and refer them urgently to the early intervention psychosis service. And if that's not possible, you would refer them to the crisis team. So the crisis team is a team which covers mental health, and they primarily deal with patients or manage patients in a community setting who are experiencing significant psychiatric symptoms, which may result in an acute admission if there was not some type of intervention. And so the crisis team really are therefore acute mental health presentations, or those patients who are at risk of further complications. And so for those patients who are not high risk, try and get through to the early intervention psychosis service as an urgent referral or possible admission, if that's accepted by the team. Otherwise, if you can't get through to them, it's the crisis team that you need to get in touch with. Thirdly, you will have some patients who are going through a prodromal phase and are not high risk. So what does a prodromal phase mean? It's relatively common before patients become psychotic or they become fully diagnosed with schizophrenia that they may start to display behavior which is unusual. So they may start to withdraw themselves, become more isolated, want to be left alone, not engaging with other people. And that could be the initial prodromal phase of the condition. And if you pick up on the prodromal phase, someone's previously had a psychotic episode and they may now be relapsing again, then you want to be referring to the early intervention psychosis service as a routine referral, so perhaps within a couple of days or a week. Or if you can speak to a specialist about it, that will be the other point of action. Now, it's not too important to know about the in-depth management of this condition for the purposes of PLAB. What you really need to know is that in secondary care, the psychiatrists would be starting antipsychotic medication if necessary, but antipsychotic medication should never be started by a junior doctor or a primary care specialist or a family doctor, although they may continue it on advice of a psychiatrist. Other treatments which can be used in the management of psychotic or schizophrenic patients would include individual or family CBT and arts therapies. Arts therapies can include, for example, painting, drawing, listening to music, gardening, and so on and so forth. So this is our second key learning point from today. Let's see how we're getting on for time. Okay, and then the third key learning point is that as doctors entering the National Health Service, you need to be aware that schizophrenic patients, i.e. those with psychotic disorders, are at an increased risk of the following conditions. So they're at an increased risk of suicide, they're at an increased risk of cardiovascular disease, which includes heart attacks and strokes. And that can be as a result of antipsychotic medication they take. Again, same logic applies for why they're at an increased risk of type 2 diabetes. But again, these patients tend to have poor diets, or there's increased risk of them having a poor diet, which can increase the risk of them therefore developing type 2 diabetes. They're also increased risk of smoking-related illnesses because they're more likely to smoke, which results in an increased risk of developing cancer. They're also at an increased risk of substance misuse and also being socially excluded because of their symptoms, because obviously people may not want to be around an individual who's hallucinating or seeing things which aren't there, which can seem strange to the general public. So when you're assessing these patients, you may want to keep in mind that because they're at increased risk of these conditions, you should be asking about these things in your history for the purpose of PLAB 2. Do you smoke? Have you had any thoughts to hurt yourself? Because you're on quetiapine, have you had any polyuria, polydipsia, or weight loss? Do you use any illegal substances? These are common questions which should be asked in a psych history. Have you got other people you can talk to? Would be an example of a question you may ask for social exclusion. So just to recap, we've covered 4 key learning points. Number 1, what is the definition of psychosis, including the positive and the negative ranked symptoms? Number 2, what is the definition of schizophrenia according to NICE, or also according to the ICD-10 classification? Number 3, how do you manage schizophrenia in the UK based on the risk assessment? And of course, secondary care management. And finally, what additional questions you may need to ask in a PLAB 2 scenario, or what additional risk factors the patient has if it's a PLAB 1 question as a result of their condition. So we always cover 2 or 3 key learning points to try and keep it simple, to try and get the most high value information over to you. So of course you can pass the exams as easy as possible to make your PLAB journey as easy as possible. So what I'm going to do is going to wait for some questions to come through. And in the meantime, whilst those questions come through, I'm just going to screen share for you guys a couple of our products and services that we have on our website. So quick show of hands, those of you who are sitting the PLAB 1 exam, in the next few months? Quick show of hands. Just raise your hands if you sit in the PLAB 1 exam in the next few months. Okay, so there's 3. That's fine. Okay, guys, you can just lower your hands. So if you're sitting the PLAB 1 exam in the next few months, Dr. Sandhu is going to put in a link into the chat box. We have a PLAB 1 mock. It's a realistic mock where we have 180 questions over 3 hours. We have a 1 hour lunch break, and then we have 6 hours of teaching by me and Dr. Sandhu with the latest NICE guidelines. So the latest UK medical guidelines. And we have 2 mock days, one's on the 9th of May and the other one's on the 1st of August between 10 a.m. UK GMT time and 19:30 UK GMT time. If you are nervous about the PLAB, and you feel like you need extra learning and you want to boost your mark on the day of the exam, we would highly recommend booking into this PLAB 1 Zoom mock. You would learn a lot and it will significantly help you boost your mark. At the moment, we've got a promotion on, so it's normally priced at £50, but the price is £19.99. And you just need to click on the date of your choice, add to cart, and then check out. For those of you who are video learners or you like learning from videos, or you like listening to podcasts, we have our PLAB 1 Gold package. So our PLAB 1 Gold package is interesting because it's don't pass, don't pay. What that means is if you use the Gold package for the PLAB 1 resource that we have, and you fail your PLAB 1 exam, we will refund you. Your money. So the PLAB 1 Gold package includes 3,750 MCQ questions, so additional 750 questions on top of the free ones. You've got 750 revision podcasts, 750 revision videos, mini lectures, and also you get some free learning flashcards sent out to your home address anywhere in the world. Like we said, it's don't pass, don't pay. So if you don't pass, you get your money back. It's very, very low risk, and would highly recommend using that resource if you're sitting the PLAB 1 exam soon. Okay, guys, quick show of hands, those of you who are sitting the PLAB 2 exam in the next few months. Quick show of hands if you're sitting the PLAB 1. Okay, so there's PLAB 2, so 6 hands went up there. Okay, guys, for those of you, 7 hands, for those of you who are sitting the PLAB 2 exam, I cannot stress enough how important it will be to attend our PLAB 2 Advanced Communication Skills course. And the reason for that is because it contains so much information that you will learn so much in that actual online course that we do. It is likely to significantly boost your marks on the day of the exam. So me and Dr. Sandhu, from 10 a.m. UK GMT time to 1700 hours UK GMT time, cover 5 high yield communication skills areas which you must know about for the exam. So things like how to deal with multiple presenting complaints, how to deal with a result station, how to deal with an ethical station, how to deal with a counseling station, how to deal with SIMMAN station with regards to communication skills. And we also do role plays. We do five role plays on the day, so you can actually practice with us live, and it's very, very competitively priced. It's only $49.99 for the whole day. We've got 2 dates, the 4th of April and the 4th of July, and at the moment we've got a discount on because it's normally priced at $74.99. If you're remotely even thinking of sitting the PLAB 2 exam in the next few months, please, whatever you do, book yourself onto this course. It will be the best $49.99 you've ever spent on any course. And lots of candidates have been through this with us already. And if you look at our Google reviews, you can go to Google, type in iMedics, and you'll see the reviews for yourself. The previous doctors who've come onto that course can testify to that. So I'm just going to stop it there and see if there's any questions. If they're not, I'm going to hand over to Dr. Sandhu, who's going to So Sana's got a quick question. Are we going to say to patients that you have psychosis and seniors will decide if you have schizophrenia or not? So Sana, to answer that question, if you are confident that this sounds like schizophrenia, so it's been going on for more than a month with the features that have been mentioned in the slides that we covered, then you can say to the patient, this is very likely to be schizophrenia because it's been going on for more than a month with the following symptoms. If it's been going on for less than a month, then it's better for you to say this is likely to be psychosis. And then of course you will say the senior psychiatric specialists will review and they will come to a diagnosis. And that's the way to do it, Sana. So it's better if you think it is psychosis, schizophrenia, or psychosis to mention it, but always say your senior clinicians will review from the psychiatric team to come to a final diagnosis. Okay, Dr. Sandhu, I'm going to hand over to you shortly. I'm going to allow you to share the screen, and we can then cover the next teaching topic, which is PTSD.
Perfect, guys. So welcome, obviously, to the second part of your PLAB revision webinar. So we're going to focus on post-traumatic stress disorder with the latest NICE guidance relevant for those sitting, of course, PLAB 1 from the clinical aspect, but also, of course, for those of you preparing for your PLAB 2, because you can easily get a station on this condition. So what we're going to talk about, well, key things, we'll define what the current UK NICE guidance defines post-traumatic stress disorder as, what the key features are, what some of the risk factors are, and how we go about managing this condition. So what's the definition? Well, basically, if you've done psychiatry or you're familiar with UK guidance for psychiatry, there's ICD-10. They're the ones that we kind of utilize for the up-to-date guidance when it comes to the major psychiatric conditions, and psychiatrists and GPs and A&E doctors have to be familiar with this when they're working here in the UK. So post-traumatic stress disorder, for short known as PTSD, is basically defined as kind of a stressful event or a situation that you perceive to be very threatening, and that's going to lead to distress in almost anyone. So it's not confined to any group of people. It affects me, it affects you, it affects, you know, your family, your friends, your cousins, anybody who sees that situation, and it's likely to have a negative effect on them. That's how they kind of define it. How will it actually happen? Now, again, it can happen to anybody, and there are things that, for example, you know, that do happen at various points in people's lives. So, for example, if someone is involved in a serious road traffic accident, whether that was you yourself or you witnessed it, so you were unharmed, you were just driving past, but you witnessed a very nasty accident or a nasty physical or sexual assault, that's likely to put you at risk of getting post-traumatic stress disorder. People who've suffered problems in childhood, and this is why when you do a psych history for the PLAB 2 exam, it's very important that you ask about the past medical history, and you may have to delve into the childhood. So, you know, Mrs. Smith, can you tell me about any problems that you had in your childhood? And the patient may open up and go on to tell you that actually they were brought up in a house where there was domestic violence and so forth. Work-related exposure to trauma, you know, trauma-based experiences. So, for example, a husband might be with his wife when she's having a baby, but it's a traumatic delivery with lots of blood and some injuries to the baby and the mother, and that husband is having recurrent flashbacks, or the mother is having recurrent flashbacks because of what happened. People who are involved in wars or any sort of conflict or victims of torture are likely to get post-traumatic stress disorder too. In terms of the diagnosis, remember we went back to ICD-10, which is what we use here in the UK when it comes to mental health. They would define someone who's likely to have post-traumatic distress disorder is someone who's directly experienced some of the traumatic events that we mentioned in the previous slide. They either witnessed it happening or it happened to them. So it doesn't matter, it's either or if they learned about something which happened to someone who's close to them. So, for example, they may not have seen the event, they may not have been involved in the event, but a police officer, for example, is describing that, you know, they found a loved one and this is what happened. And when they're told that news, they start to kind of reenact what may have happened, and that causes them to have post-traumatic stress disorder. First responders, so some people who work in like the emergency professions, whether you're a fire officer, a police officer, doctors as well, child protection, people who are involved in that when they're dealing with child abuse cases, can sometimes trigger off nasty memories in people's heads when they think about what happened during the event. So to actually diagnose post-traumatic stress disorder, you need to have had a cluster of symptoms, but you don't have to have all of them, but they need to be present for at least 1 month. And the key thing is the first box here. So the patient's going to describe re-experiencing the symptoms re-experiencing flashbacks to the event that occurred, and that will happen at daytime. For example, they're having constant thoughts, and it may happen at night time as well. For example, they close their eyes and they see that event again, or they have nightmares. They keep going over what they witnessed, and it's stopping them from functioning normally. Then there can be other factors. So, for example, avoiding things. So, you might not go down a certain stretch of road because it reminds you of a fatal car accident that happened, or they might not want to go past a certain school because it reminds them of a child protection case that they dealt with. Hyper arousal, and that basically means that someone who is very, very alert and is kind of hyper alert to anything around them. You hear a noise and you panic and you suddenly become very alert. Who was that? What was that? Is there someone there? Is there someone hiding in the bush? You start to go through those kind of states. Negative effects on mood and thinking. Emotional numbing. So emotional numbing is basically where they tend not to have emotions anymore, and that's because they feel so distressed by what they've seen that they no longer feel happy, and they no longer kind of, if someone gives them good news, they're not really kind of happy how they would have been if they hadn't have witnessed this event. And that leads with the next two boxes, like disassociating yourself from your thoughts and feelings, and your emotions are all over the place, and that then impacts on your day-to-day life, where there's difficulty maintaining relationships and a negative view of themselves, because they start to kind of, maybe they blame themselves that they should have done more to protect the person who was injured or hurt. And so you can see how it can be quite a very detrimental mental health condition. The risk factors. So there are certain occupations, as we touched on before, that you should know of, and you may get a case based on when you're delving into the case, you may find that the patient in PLAB 2, for example, is one of these professions. So people in the armed forces, people serving in the army, or people who've left the army may have seen things happen to their colleagues or to other people, or they may have even done something where they felt bad because they felt that they did the wrong thing. They may have attacked somebody or done something which they shouldn't have done, abused their power, and that thought goes through their head and again. Members of the emergency services, so ambulance personnel, police, prison officers, fire officers, obviously doctors, nurses that are kind of exposed to things. So if you see someone who's come into A&E with a road traffic accident and they've got blood coming and they've got a broken leg, that's naturally going to have a negative effect on your mental health. Journalists, sometimes they go into conflict zones. Refugees and asylum seekers may have seen some really nasty things. They may be coming away from a war zone, and that's had a really bad impact on their mental state because of things they've seen happen to them or their family members. And of course, severity of the incident. So the more severe, the more gruesome, if you like, the event, the more likely you are to have some element of post-traumatic stress disorder. Other things to be mindful of. So there is some evidence to suggest that females tend to have more post-traumatic stress disorder than men, but it will depend on what they've actually witnessed. Younger age people, so again, people who are younger tend to kind of have a higher risk of getting post-traumatic stress disorder, having lots of other stresses in your life and previous trauma, and also coming from a lower socioeconomic, socially disadvantaged background may be a strong risk factor for developing post-traumatic stress disorder. And that's probably because they're probably less likely to seek medical help, less likely to go and see their GP or mental health practitioners to get some support for the problem. And if they've got a history of other mental health problems like anxiety, depression, then of course they're more likely to develop PTSD as well. So how do we manage it? Well, NICE defines two ways to manage this condition. So subclinical post-traumatic stress disorder. This is somebody who's got the symptoms usually for less than a month. They're not interfering with their day-to-day life, but they do cause them to feel like something's not quite right. They have had some flashbacks about something they've witnessed, but it's okay. They're just about getting away with it. It's not reached a month, and it's not affecting them day to day. The NICE guidance would say we should do active monitoring. So in other words, get a follow-up. So the GPs would bring them back within a month to see if this patient is getting better. If they are, there's nothing else we need to do. We just safety net and bring them back if they have any further problems. And of course, if they do have problems, we move on to the next stage of the algorithm, which is essentially here. So you've got clinically important, NICE defines it as clinically important post-traumatic stress disorder. And this is where someone's had the symptoms for more than a month and they're starting to affect their day-to-day life, day-to-day flashbacks, nightmares, affecting their relationships, affecting them at work, stopping them from doing things. They're avoiding things that remind them of that event. And here we need to think about 2 or 3 things. One is a specialist mental health service, which focuses on trauma-based CBT. And the second is the option of drug treatment as well. And if we delve into this a bit further, so the psychological therapies are often offered for this condition. The common one is trauma-based CBT, and they normally do up to 3 months of this. And you've got 2 aspects of this. You've got exposure therapy and trauma-focused cognitive therapy. So exposure therapy is where the patient confronts that nasty event, that memory that they've got embedded in their brain, and they're repeatedly exposed to that situation which they've been avoiding. So that kind of makes them feel very scared. And then you've got the trauma-focused bit, and that's where that identifies and modifies any kind of abnormal thoughts that you're having about what you witnessed. And then the therapist teaches the patient to start thinking differently about that same situation that they've witnessed, so they can overcome those nasty thoughts that they've been having. Then you've got another interesting thing. There's eye movement desensitization and reprocessing, known as EMDR. And again, NICE normally recommends that we refer patients for at least 12 sessions. And this is for the more complex cases where there's lots of nasty things that they've seen over a period of time, often given to children from the age of 7 years. And it uses kind of stimulation, so eye movements, tones, tapping sounds, which focus on memories and associations. And it's thought to help your kind of brain understand those flashbacks that you've had and try and make sense of that experience, and then alter the way you kind of remember that experience and think about that experience. So quite a complex method, but quite commonly used by psychiatrists for patients with post-traumatic stress disorder. And then of course you've got medication, and there is an option of doing both, or going for psychological therapies first and then medication. And the classic ones that we give are antidepressants. There's things like venlafaxine is a common one, or the SSRI drugs. So the classic 2 are sertraline or citalopram. Normally patients will have to be on these for 6 months. So remember, in PLAB 2, whether it's depression or PTSD, you always tell the patient it's going to take 2 or 3 weeks for effect. Don't stop it suddenly, and you will need a 6-month, you will need to be on it for 6 months, and then we'll wean you off it slowly. So they're the key counselling things for this. Support groups. Now, what's the difference between an average PLAB 2 candidate and a top scoring PLAB 2 candidate? The difference is the top scoring PLAB 2 candidate will know about what actual support groups are available in the UK. So an average PLAB 2 candidate will say, Mrs. Smith, I can refer you to support groups, I can send you some details, and they might give them a paper, but they don't mention any. The top scoring candidate will say, Mrs. Smith, now there is another thing which we can talk about. There's some support groups. For example, have you heard of CRUISE? Have you heard of Combat Stress? Have you heard of the Rape and Crisis Centre in England and Wales? I can get you some information and they can give you some support. How does that sound, Mrs. Smith? The examiners will sit in the corner and be like, well, this guy or this girl knows what he or she is talking about, because they are very specific and you've picked out. So this is a very useful slide for useful support groups for PTSD. There's Combat Stress, which is a military charity which helps people who were in the army and have suffered with PTSD. There's the Rape Crisis in England and Wales, again another UK charity that will have a specialised service for women and girls who've been raped or experienced some form of sexual assault. There's a Victim Support, which is a free and confidential help support service for victims of crime. There's CRUISE, which provides support and information for people who've suffered a bereavement. So sometimes people get post-traumatic stress disorder when a loved one has passed away. And so it's important that you know about CRUISE. Plays a good role in palliative care and helping people to get some bereavement counselling. There are 3 other ones to be mindful of as well. There's Veterans UK that will provide support for people who've been in the military. There's Anxiety UK, which is a charity in the UK that will give you fact sheets on anxiety problems, including PTSD. And there's also a US website as well, which NICE mentions, which is the National Child Traumatic Stress Network. And that's got videos and information sheets for children who've experienced a traumatic event. And these are things that you can signpost your patients to. That leads us on to the questions. If you haven't done so already, I'm sure you probably are following us on social media, Instagram at Inspire_Medics, the Facebook group Inspire Medics Home. pop into the groups, YouTube Inspire Medics as well, and Twitter iMedics for revision. And that will be the end of the talk. If there's any questions, guys, do let us know. I think there might be a couple of questions that may have popped up. So any questions, guys, that you wanted to ask? I'm going to just get rid of this. Good. I don't think there is, Mo. Have you got any questions on your side? Or?
No, I think that's it, guys. Just don't forget, we've got the PLAB 1 Gold package, which is don't pass, don't pay. If you don't pass, you get your money back. And number 2, we've got the PLAB 2 Advanced Communication Skills course. This is stuff you will not learn in other places. We've jam-packed with information, tips, techniques, and methods to boost your score for communication skills in the PLAB 2 exam. Highly, highly recommended. Only $49.99 with the current promotion. And then finally, we've also got the PLAB 1 mock. So the PLAB 1 mock is a full day mock, 3 hours in the morning, 1 hour lunch break, 6 hours worth of teaching, and it's worth obviously attending that. So one question for you, Dr. Sandhu, is Sana, who's got a question in the chat box.
Yeah, so just saw that. So Sana's question, so thank you, Sana. If patient comes in within 1 month, then we'll not do anything. Very good question. And the answer is yeah. If it's subclinical and they're okay and it's within a month and they're stable, we bring them back within the next 2 or 3 weeks. So within that month to see how they're getting on. If they're fine, you don't need to do anything. If they are obviously still struggling, you go down the route of psychological therapies or medication like venlafaxine or SSRIs. Charles joined late. No problem, Charles. Hope you're well. We will, of course, put this back into the Facebook group. It will be on the YouTube channel as well within the next 24 to 48 hours. Don't forget to follow us and on the social media channels, and obviously sign up depending on what you're preparing for. The PLAB 1 free PLAB 1 question bank. The PLAB 1 mock is a very good experience for those preparing for the PLAB 1 exam. They'll be teaching in the afternoon. With about 200, 300 plus topics covered. And of course, the PLAB 2 Advanced Communication Skills course, which will be updated with the COVID news stations. And of course, lots of kind of opportunity to do live role play there as well. So I don't think there's anything else to add from me, Dr. Mo, unless you wanted to add anything. Or...
Just one last thing, guys. We had a slight issue with our email server 2 weeks ago. So you may notice some of our emails are going into your junk folder. If that happens, click on the email and you'll have an option in Gmail, Yahoo, Outlook, Hotmail. This is not junk. And if you reassign it as not junk, it will then go into your inbox. And then future emails from iMedics will go directly into your inbox folder as opposed to your junk folder. So if you wouldn't mind doing that, and that way that helps us as well, because then Google, Yahoo, Gmail remembers that, oh, this isn't a junk email from iMedics, and the rest of the people who are on those platforms can get their email in their inbox as opposed to their junk folder. We had some small technical issues. We're trying to sort them out, but that would help us going forwards. Guys, hope you enjoyed the teaching session today. We've got another one in about 2 weeks' time. Hopefully, we'll see some of you on our PLAB 2 Communication Skills course or our PLAB 1 Big Mock. And then, of course, if you're sitting your exam soon, hopefully they go well, you do pass. If you're struggling to get seats for PLAB 2, we've heard from loads of candidates that they're struggling. Hopefully you'll get them in the next few weeks as the applications process opens up to further candidates. And finally, of course, please take care, stay safe wherever you are in the world. We look forward to having you as colleagues in the UK once you've actually passed all your exams. So it's bye-bye from me, Dr. Mo, and of course the same from Dr. Sandhu as well.
Yeah, bye-bye guys, stay safe and we'll see you very soon.